Good afternoon and welcome to today's COVID-19 Town Hall. Thank you for joining us today. If you have questions, please enter those in the Q&A module and we'll answer them directly. And now, I'd like to introduce our moderator, Patty Charlton.
Hi, good afternoon, CSN family, and thank you all so much for being here with us today. And so thank you for this joining us today on this very special COVID-related town hall. And so I'm joined today as a co-moderator, Bill Dial from our Chief Human Resources Office. This panel today is some very distinguished subject matter experts in the area of COVID. I'm going to share a little bit of their bio with you shortly, but this town hall today is really focused on the COVID environment as a whole. We will not be speaking today on things that relate to leave and or any specific individual situations, telecommute and or your class schedule, but this is an opportunity to really get the knowledge and expertise of our amazing panel today on any questions that you might have on COVID. And so I'm going to start first with giving a very quick and brief introduction, and then Bill Dial and I will be supporting any of the questions that are coming through, and thank you all again for joining us. And so first, let me share a little bit of information about our panel today. So first, Dr. Pat Amor. Pat has 40 years of clinical laboratory experience in a variety of settings, including large and small hospitals, as well as a physician office laboratory. Prior to joining us at CSN, she was the founding manager of the Southern Nevada Public Health Laboratory. And I do know that she did work with one of our other panelists, Brian Labus, in that very environment. So this should be a fun afternoon. Southern Nevada Public Health Lab was established in 2003 to provide bioterrorism testing for Southern Nevada. During her 13 years managing the Public Health Lab, she also established foodborne illness outbreak investigation and sexually transmitted disease testing capabilities for the health district. Additionally, Pat and Heidi Schneider, the program director in their program, have been instrumental in providing our COVID testing environment at CSN and in Southern Nevada. They've been an instrumental part of building that complement. So welcome, Brian. Brian Labus is an infectious disease epidemiologist and assistant professor at the University of Nevada, Las Vegas School of Public Health. He leads a 200-student UNLV contact tracing team and has participated in all aspects of UNLV's response and has been very helpful to us as well, and has been interviewed about, I think he told me 800 times, but I think it's probably close to 1,000, Brian, by local, national, and international media on the COVID since the start of the pandemic. In March of 2020, he was appointed to Governor Sisolak's COVID-19 medical advisory team. He received a bachelor's degree in biology from Purdue, a master's of public health degree in infectious disease from the School of Public Health at the University of California, Berkeley, and has a PhD in public health with a concentration in occupation and environmental health from UNLV. And again, Brian has been an amazing resource for the CSN family as well. So please welcome also Sherry Lindsay. Sherry hails all the way from Shreveport, Louisiana, and has been a resident in Las Vegas for 18 years. Her passion is truly in educating nurses to become excellent healthcare providers. She has been a nurse for 34 years and held various positions in nursing. She is currently a tenured faculty member and the program director of practical nursing at CSN. She also holds a doctorate in nursing practice, emphasis on executive leadership from the University of Nevada, Reno. And her master's degree is in administration from Central Michigan University and a master's in nursing education from Purdue University Global. Sherry has also been an instrumental part in leading our student and volunteer vaccinators in support of the deployment of our point of distribution, our pods, for COVID vaccinations, both at CSN and at UNLV. So please welcome Greg Bain today. Greg has been an emergency manager practitioner for over 28 years, serving in the United States Coast Guard and specializing in search and rescue, hurricane response and recovery operations, marine environmental response and salvage operations. He also served as a the Coast Guard Search and Rescue Mission Coordinator for the response to Hurricane Maria in 2017 and worked with the 1st Air Command at Tyndall Air Force Base, Florida. He also joined the University Police Services as their Emergency Management Coordinator, and Greg is currently the Emergency Response Coordinator with on behalf of all of our Southern Nevada institutions, CSN, UNLV, and Nevada State, with the Clark County Board of Commissioners and the mitigation effort. So he is our representative with the county. And then finally, please welcome Carrie Sedlicek, our Director of Environment, Health, and Safety at CSN. Carrie has 15 years of diverse safety and environmental experience through her service as an environmental science officer in the U.S. Army, as well as civilian positions in healthcare, biotechnology, and now higher education. Carrie is the absolute forefront, and she is the heart of our COVID response here at CSN, and she leads our areas in contract tracing, case management, promotion of behaviors to reduce risk of transmission, PPE selection, acquisition and dissemination, and on-campus protocols and compliance. So we have an amazing team today, so we want to hear your questions, and so I'm going to turn it over to Bill so that we can start with our questions. How's that?
Thank you, Patty. And again, I want to thank all of our panelists today for taking time out for this very important conversation to have this afternoon. We have almost 300 attendees today on this, and so I want to go ahead and jump right in. Please begin submitting your questions if you would. But I guess our first question, perhaps to Brian and Sherry. Are Nevada research institutions conducting or planning to study COVID and long COVID, post-COVID patients within our community and state?
Brian, you want to take that one?
Sure, I'd be happy to. I think for the rest of all of our careers, probably the careers of any of the students watching this today, there will be research being done on COVID. I don't think there's any way to avoid this. This is going to be a huge area of research for a long time to come. Not just the acute effects, but the long-term effects. We don't know what happens years down the road. We've seen people that are still fighting COVID a year later, still having symptoms. So there is definitely a lot of interest in that. We've been doing research on things related to vaccine hesitancy, on the disease itself, all sorts of different things. So I think for the better part of the rest of this century, we're going to be looking at this pandemic and trying to learn from it. So it may not be exactly what everybody thinks we should be doing, but I think it's going to be a lot of research in a lot of areas that touch everything from the biology to the mental health to the social effects and the economic effects. This is going to be people's careers. So absolutely, we're going to be looking at this for a long time to come.
All right, we'll jump into the next question. And perhaps this will go to you, Carrie. Will teaching faculty have to wear masks while instructing live in the classroom? If so, students may have problems hearing teachers speak with masks on.
Thanks, Bill. So yes, with the current mandate from the state, we all need to be wearing our face coverings while on campus. But I will say that my team, we've ordered a clear mask option that we've had a few people test out and got some positive feedback. So if that's something faculty or a certain department is interested in that specific product, just reach out to me or even just wellness@csn.edu, and we can try to see if that would be a good option for lecturing.
So Bill, so I think the next question that we have for our panel today is based on the email sent out this morning. What is the stance on a vaccine mandate? If the State Board of Health has not placed this order, are you still intending to mandate vaccines or testing? And that might be something for Brian and possibly even Sherry and or Pat as well. So we've got mandatory testing, vaccinations, and the like. So how about we hear from several of our panelists? Brian, let's start with you.
Sure. So the governor has said that as of August 15th, you have to be vaccinated as a state employee or get weekly COVID tests. So it's something that we don't really have any say in. We are being told that's what has to be done for all employees of the state of Nevada. So that includes all of us throughout the NSHE system as well. And that's something that is designed to do a couple of things. First, It is designed to protect people on campus. We want everybody vaccinated, but if you're not vaccinated, we want to test you to make sure that you're not positive and exposing other people to disease. But more importantly, it's designed to be a little bit inconvenient. It's something that you're going to have to do every single week if you're not vaccinated. So you do have that choice still, but it's much more convenient and easier on you to get vaccinated. And we're trying to improve those vaccination rates as much as we can, and any of the tools that we have to do that are welcome.
Great. So Sherry, can we ask your input on vaccinations and what people can do?
Thanks, Patty, for that question. Vaccinations are really, really, really important for everybody to do. We do not want to have people with, that are passing virus that are not non-symptomatic. So vaccinating and getting vaccinated and encouraging your family to get vaccinated is really important to actually get those numbers up, as well as provide protection for all of us.
Great, thank you so much, Sherry. So I think the next question is going to lend itself to Pat Moore. So Bill, do you want to ask that question to Pat?
Sure, Pat. So there are a number of businesses providing COVID testings, including tests being done at home. Are the home tests accurate?
So accuracy is an interesting concept because there's a number of components that go into whether or not a test is accurate. And I just happen to have one of the tests here. I'm actually using this for my students to have a discussion about how these tests are performed. So when we talk about accuracy, we're looking at how well does the test perform, and all of these tests are approved by the FDA. These over-the-counter tests have been approved so that a person with who doesn't have any clinical laboratory experience would be able to perform the test, provided they follow the manufacturer's instructions, which means that you need to collect the right sample, you need to time the test and perform the test properly, and you need to interpret the test results. And all those three components are a real large requirement that you have to ensure that the testing you're performing at home is accurate. If you follow all those components, then you're going to get an accurate test result. But the other piece of accuracy also is tied into how prevalent is SARS-CoV in the community right now, and what status do you as a person have who's having this test performed. So do you have any signs or symptoms? Were you in contact with anyone? Because it's always difficult when you're doing this testing in somebody who's asymptomatic. So you have to look at all of those components. It's not just the test result, it's all those other pieces that have to be looked at. The CDC has a really good testing tool on their website that I think, Patty, we've got that available on the CSN website, or that link is there. And the nice thing about that tool is it asks you all of those other questions. And then it gives you recommendations for what kind of test should you have performed, and how do you interpret those test results.
Great, thank you so much, Pat. That was fantastic, and you're right, that is available on the CSN webpage. Thank you so much, Carrie. So our next question, and this might be more for Brian, sorry, Bill, I may have to call you in a little bit, and for Greg. If we are going to attempt to enforce a vaccine mandate, how are we going to collect the data, and who will be collecting this data?
Well, I can maybe jump in. I will put on my CHRO hat and stop being a moderator. And so this is a process that we're working out right now. And what I will say is, we look at this, and as we look at collecting data and who will be collecting data, what's going to be of utmost importance to us is ensuring the integrity of the process, but also the confidentiality of the individuals. And so we know that the deadline is coming from the governor's office, and I believe that deadline was August 15th, if I'm correct, Patty, for the beginning of collection of this. And so this was very new. It came out late last week, and so I spent some of the time some of my time over the weekend putting in place conceptually some internal business practices and operational procedures so that we can ensure, as we comply with the directives from the governor, that as we collect this data, that it would be housed in HR, but again, very confidential, separate from any personnel file or anything of that nature. So a bit more to come on that. I about have that finalized, but I guess conceptually that's where we stand. And I don't know, Greg, perhaps if you have anything further to maybe add on that.
Thanks, Bill. No, I think you're absolutely right. There's not a lot of granularity to the plan or the policy just yet. It's still in the works, being developed. So we expect to hear more from the state on requirements and just how they want to handle this. So the largest repository of vaccination information is the state's WebIZ system. But in order to access that, there would have to be, as you said, privacy protections, information sharing agreements to make sure that that information is handled appropriately. So all of that has to be discussed, and it's currently ongoing, but we don't know exactly how that's going to play out.
Great. All right. Well, thank you so much. So our next question is, and I'm sorry, this is going to be more focused on Brian and with Pat. So can you please describe the difference in COVID testing? We have PCR tests, we've got Finex, we've got rapid tests. When COVID first started, we heard a lot in the media that there was a lot of false positives or false negatives. How do we know what's right, and how do we know that the science has improved? Can you share some information? So I don't know if we want to start with Brian and then shift over to Pat.
Well, I would say start with Pat, because Pat's the person I ask these sorts of questions to. She's the expert I turn to. So Pat, take it away.
The floor is yours, and Brian, you can rest your breath. How's that?
All right, so there's actually 3 different types of tests. So there's an antibody test that is going to identify whether you had a previous SARS-CoV infection. It is not going to give you information about whether you are acutely ill. Are you currently sick with SARS-CoV? And then we have the other 2 types of testing, and the test that we typically are using as a gold standard is a test called a PCR, which is polymerase chain reaction. And what that test is looking for is 1 or more of the viral RNA genes. So this test is highly sensitive, which means you end up with few false negative results. And it is highly specific, which means you end up with few false positive results. The downside on the PCR testing is it takes time. It's 1 to 3 days. And the other piece of information is that it is testing for RNA. So if RNA will be in our body, and a person who's been infected with SARS-CoV will have RNA in their body for a long period of time, but that doesn't necessarily mean that they are infectious and can transmit the infection. So you can have a PCR test that's positive, that's many days or even weeks after you've been infected. And so you also, as I said before about accuracy, you need to interpret the test results based upon multiple different components, and one of those are signs and symptoms and the status of the patient. The other piece is that you can have antigen testing. So the antigen testing is rapid. It can also provide you with very quick information of whether or not a person is potentially infected with SARS-CoV. And what it's looking for is a viral antigen or a protein. So these are also highly specific, which means you have few false positives, but they can have a low sensitivity, which means you can end up with false negative results. And so with the antigen test, while you can get a rapid test result, you can potentially might need to have a confirmatory test, which is the PCR, in order to confirm find out whether the person really is potentially infected. So the question is has the science improved? Well, the test is the test. So you're going to end up with false negatives, false positive, no matter what test it is that you run in the clinical laboratory. The main component here is following CDC's recommendation of how you're going to interpret those test results. So you look at prevalence in the community, and you also look at the status of the person. Were you in contact with people who were potentially infected? Do you have signs or symptoms? You have to interpret the test results based on those components as well. So while the science has improved because we've developed multiple different types of tests, and we certainly have far more options than we did a year and a half ago. But again, these all have to be interpreted based on those two things that CDC said: prevalence and what's the status of the person. Brian, you got anything else to add?
No, you're perfect, Pat.
Okay.
I think, Patty, our next question may go to Carrie, and it came to us, and this individual indicates that they don't have an office. Is it okay for an employee to remove their mask while they're working alone in their workstation and their workspace?
Thanks, Bill. So the current mandate is all personnel inside NSHE spaces and CSN spaces needs to wear a face covering unless you're in a private room or private office with the door closed. So even if you have an office and you're in the presence of other people, you'll need to wear that face covering. And then if you work out in the open area, then yes, you'll need to wear your face covering.
Great, so thank you, Carrie. So this next question, I'm gonna throw it to Brian and I think to Sherry for her input as well. I'm concerned that I have children at home that are not able to get vaccinated. With K-12 school starting soon, how can we best protect ourselves and our family from exposure to COVID within our homes?
Well, really nothing has changed from where we were a year ago when we were dealing with this. If you're sending kids to school, there's that same risk of being around other people. Keep in mind that the risk for kids is lower. They don't spread the disease as easily. And if they do get infected, they tend to have very mild symptoms. And the younger they are, the milder the disease is. So when you get to the high school age, they're more like adults. But below that, kids really experience COVID quite differently than the adults do. But of course, the concern is a kid going to school and picking up the disease and bringing it home and spreading it to the rest of the family. And if they're not wearing masks, if it's not required by a school policy, you're really limited in the options that are there. I mean, of course, you can ask your kids to wear masks, but if none of their classmates are doing it, it's obviously gonna be really tough to get your kid to do it. They're gonna tell you they're doing it, but they're probably not going to. And so that's going to be a challenge. But beyond that, I think we have to think about COVID control at the community level. This is why we were trying to get everyone vaccinated so that we can control things, whether you're in a school or a store or your workplace. It's really the only way to stop this because we can't focus on each of those individual places. We have to think of us as a population spreading disease back and forth between each other. And that's why high levels of vaccination among the people that are eligible are very, very important. And later this year, we do expect to see the vaccine approved for younger and younger children. So there will become a time in the next 6 months or so where kids can get vaccinated. We're just not quite at that point yet. But if your kids can't get vaccinated, you should get vaccinated now, not just to protect them and protect yourself, but to protect our community as a whole.
Great, thank you, Brian. So Sherry, can you add any additional thoughts and perspective of how we can protect ourselves? Oh, Sherry, you're muted. So sorry. Unfortunately, Sherry is still muted. Do apologize. So.
Oh, here I am.
There you go.
I'm here. So I think Brian actually hit every single point. Vaccination is that one thing that's going to keep us all safe. And for younger children that are in a house, if the parents are vaccinated, there's a lower chance for them to catch and, take anything from, home to other school, to school with them if they were to get exposed.
Great. Thank you so much.
Thanks, Sherry. And Sherry, I think this next question is for you. So nutritional deficiency, which half of Americans suffer from, is critical for a well-functioning immune system and for optimizing vaccine efficacy. Why is it that vital health information and effective COVID treatments still seem to be suppressed from the public?
Or Brian, you're welcome to join
Brian, I think that one would be for you.
Well, I don't think there's some grand conspiracy to keep any important health information from the public. We provide general information on how to best protect yourself and stop disease transmission. But it isn't like there is a particular supplement or something like that that really makes a difference in COVID, other than generally protecting your health and good nutrition overall. It's not like there's one particular supplement that makes a difference or anything like that. A lot of people have focused on things like vitamin D, and that was really a misunderstanding of the studies in vitamin D. It wasn't that more vitamin D made you better protected against COVID. They found that people had deficiencies tended to get more or were more likely to be infected and have more serious disease. And if they corrected the deficiency, they were back up to the normal risk of everyone else. It wasn't that vitamin D made you, it protected you in any way. It was just the people that were left unprotected because their levels were too low. And so people have focused on that a lot. But I don't think there's some grand conspiracy to keep that information from the public. There isn't just one particular nutritional approach other than general good nutrition and just the general things we need to do to protect our health and support our immune systems that are going to provide any extra benefit for COVID.
All right, thank you so much. So this next question, Brian, I apologize, I think it's for you again. So
it's all right, that's why I'm here.
So the Washington Post recently shared a CDC report that said a fully vaccinated person can spread COVID equally as an unvaccinated person. Can you explain why this is happening when face coverings were removed, or why did face coverings get removed as the vaccinations have been available for everyone, and what can we do to know that the vaccinations is effective?
So the face covering mandate change was before the Delta variant was out there. And so that was really the big difference. When the Delta variant showed up, the entire game changed. So I wouldn't worry about Delta variants and how the face mask part of it was, because that was prior to Delta. What we found is that people with the Delta variant basically have about 1,000 times the viral load of the previous variants that we saw, which means if you're infected, you produce a lot more virus. That makes it easier for you to spread it to other people. That's why it spreads so easily. The vaccine itself will help prevent you from getting infected in the first place. It's not perfect. It doesn't prevent 100% of infection. So if you get infected, you could spread it to other people, but it does a good job of stopping you from being infected in the first place. And even more important, if you are infected with that particular virus, the hospitalization and death rates are very, very low. Close to 99% of our hospitalized cases are people who are unvaccinated. And we have seen a few deaths in people who are vaccinated, but they are very low compared to the deaths that we see in unvaccinated people. So the vaccine does an excellent job keeping you out of the hospital, keeping you from dying, and keeping you from getting infected in the first place, which then is going to prevent you from spreading it to that next generation. Once the virus gets in, it's based on the biology of the virus. It doesn't care that you were vaccinated at that point, but it helps keep it from getting in the first place.
Thank you so much, Brian. So, Bill, I think our next question is also for Brian, is are you satisfied with NSHE's response to COVID-19, especially with the Delta variant? What is your view of the vaccination mandate and that it can only be determined by the State Board of Health?
So, of course, I'm going to have to be happy with it because I'm part of that. So I've been making recommendations for the last year and a half, and I've done everything I can to try and steer us safely through this pandemic. Not everything we do is always going to work. We recommend vaccination for everybody because we have a tool that's going to protect people, and half the country says, no, I'm good. And so that right there is a challenge. It doesn't matter what we recommend and how we approach it. But our goal the entire time has been to have classes in as normal of a situation as possible while still protecting people. When it comes to the vaccine mandate, I absolutely agree with them. I wasn't surprised by anything that I saw in the report they put out, I think it was yesterday, that said that the State Board of Health has to do that because that's the way the law is written. Of course, there can always be exemptions for that. There can be an emergency order or something like that. I don't know how that process would work, but this is the way vaccination works in Nevada and has for a long time. When I was with the health district, we added the hepatitis A vaccine and we added the chickenpox vaccine when I was there, and it required going to the State Board of Health, having them change the Nevada Administrative Code, and then it adds it to the vaccines that have to be required for people. We saw the same thing for the meningococcal vaccine for college students. That's the way the process works. So for me, it's not a surprise at all. That's the way the system is set up, where the State Board of Health makes those decisions for everybody. That sets the Nevada Administrative Code, and then we all have to follow that code. So the fact that they put that out, there wasn't a single thing in there that surprised me. That is exactly the way the process is supposed to work.
Thank you, Brian. So I think next question I can present to this whole panel, but the vaccination was expected to result in a return to normal. And That's changed. So why did the CDC, the White House, Nevada, state of Nevada, Clark County remove mask mandates and now reimpose them?
I think let's, I don't know, let's start with maybe Pat and then kind of work around the group. And I know that not everybody's a part of that decision, but give your thoughts and perspectives to the participants today.
So Brian's probably the best person to answer this one, but again, I think this virus mutates, and we know that going in, and because it mutates, we need to adjust as that mutation occurs and to ensure that we can keep ourselves safe. My hope is that people will get vaccinated, because the more people the more chances of this virus getting into the unvaccinated population, the additional chance we have of more mutations. And I think the biggest concern we would all have is that we end up with a mutation that then makes the virus resistant to the vaccine. So vaccination is the key, is the tool for having this put in place. The masking, you know, I tend to follow universal precautions with the mask. So I'm just assuming that everybody's around me is potentially infected, and I'm just wearing a mask because it's going to protect me, and I'm going to make sure that I feel protected. So I think that we have to all work together to ensure that we can continue to stay as, air quotes, normal as we can, and that means we need to follow the guidance that we're getting from the state and from the CDC.
Great, thank you. Anybody else want to add to the response? Sherry, Greg, Brian?
Oh, Patty, this is Greg. Yeah, I think one of the things that that I've discussed with Brian is we always reserve the right to be smarter today than we were yesterday. And once we know more, as Pat alluded to, then we make decisions based on that new information. So initially, we had thought that it was a very, very, very low probability that somebody who was vaccinated might contract or even pass the disease on to someone else. We know that there's a potential for that now. So again, the game has changed a bit, the information has changed, and we're making the best decisions that we can with the information that we have.
So I'll add my piece here. When I teach public health to undergrads, I tell them that public health is the intersection of science and politics. I can say this is the right thing to do scientifically, but we have to think about the political side of it. And I don't just mean the governmental politics and fighting on CNN or whatever it is. I mean what we decide to prioritize as a population and what things are important to us as a community. And so as a scientist, I can say, these are the steps you need to take to stop disease transmission 100%. I could have stopped this pandemic early on, but it would require locking everyone in their houses, not letting anybody out, and waiting to see who survived at the end of it. It would work. However, it's not something we're obviously going to do as a community. And so we have to balance these scientific approaches against what our community is willing to accept. Masks have obviously become a huge political issue. They are effective, they are safe, but some people have chosen that hill to die on, that I decided to destroy all their freedoms by making them wear a mask when they go out and do whatever they want. And so we had to take those sort of things into consideration. But what it really comes down to with it is we put the masks on to bridge us to vaccination. The disease was under control. The vaccine was here and our numbers were going up. And at that point, we said, things are in the right direction. We can back off some of these different steps that we had. And we've done that all along over the course of the pandemic. As a public health person, no matter which thing it was, I was always going to think it's too early. But that winds up being all of us being overly cautious. But at the point when we removed the mask mandates, we were fighting the old virus. And then a few weeks later, a brand new enemy showed up. So had we kept going with the same variant that we dealt with before the Alpha variant and the Delta variant, we'd have a lot of people vaccinated. We wouldn't be seeing what we're seeing right now. New enemy shows up. We have to change our game plan and go back to a lot of the things that we did before, because it was a new situation with a virus that spreads much easily and the rules had changed on us.
Great. Thank you so much. That was a lot and a lot of good information. So is this true or false? The Delta variant of COVID is more transmissible but less dangerous.
Partially true, partially false. So it is much more transmissible. It is basically equal in terms of dangerousness, but however you want to describe that, the difference is our death rates are lower, and it's not because the virus is less deadly. It's because we vaccinated all the old people who are dying from COVID. So our vaccination rates in people 65 and older are very good. We're doing a good job with that. Those were the people at highest risk. So if we take them out of the equation, it looks like the death rates are lower, and it looks like the hospitalization rates are lower because we've shifted the disease burden to a younger population with fewer underlying conditions. The rates among any one of those age groups are the same, though. So basically the difference between this variant and previous variants is that it spreads a lot more easily. Anything else you see is because we've added vaccination to the picture and we vaccinate unequally among different populations.
Thanks, Brian. Sherry, possibly a question for you. We have an individual who's asked a question. I'm concerned about getting the vaccine as I have allergies and high blood pressure. Can you maybe address those concerns?
Yes, thank you for that question. Great question. If a person has high blood pressure or even allergies, the COVID vaccine shouldn't interact with any of the medications or treatments that you're doing for your high blood pressure or your allergies. However, the caveat to that is that you have to make sure to check in with your provider. Your provider is going to give you direct information in regards to medications, the doses, and those types of things. So the first thing I would say is to check in with your provider and make sure that you and your provider are on the same page when you get the COVID vaccine.
Great, thank you so much, Sherry. That's a great response, and thank you, because I know that several people have that concern. So the next question, and I'm going to probably throw this out to Brian and maybe to Bill. Sorry, Bill. I'm concerned about being forced to take a vaccine that I'm not comfortable with yet. I would like to wait a few years to see what effects the vaccine might have on people. Is this something that is going to be forced on employees throughout Nevada? Brian or Bill, jump on in.
Well, I guess I can take the employment part. To my knowledge at this point in time, and I know there are some legal questions behind this as well about forcing a vaccination or mandatory vaccination. So I think more to be determined. And again, I really like the approach that Greg talked about, is that, and I think I've talked about in previous town halls, that we have to be flexible, but we are also going to follow those directives that are given to us from INCHE and from the state, but that's also going to have to be guided by some legal and by the system. And so I think that's where we're at. But what I do know is that if an employee is not vaccinated, they will be required to be tested. And so I can state that with certainty, but I have not heard anything up at this point of a mandatory vaccination for state of Nevada employees. So Greg, I'm not sure if you have anything further on that or not.
Thanks, Bill. No, I think the approach that we've taken to date has been an either or. You can choose to be vaccinated, or if you remain unvaccinated, then there will be certain steps that you have to follow. So we haven't gone down the mandatory vaccination road where we're saying you absolutely have to be vaccinated. We've taken an either or approach to this point, and I would expect that to continue.
Yeah.
Brian, I don't know if you wanted to maybe talk a little bit about, I guess, waiting to see for a few years of maybe what happens.
Well, the only thing I can tell you is that if you wait for a few years, you will be unprotected for a few years. That's probably the only certainty when it comes to the whole situation you're describing. It's natural to be concerned about something you're going to put into your body. The FDA is doing the review, and we expect to have full approval where they look at all that information. So if you're concerned about that, I would encourage you to look at the actual data, the studies that were submitted to the FDA and all that. I would also consider this. The vaccine itself is basically producing one tiny little protein from the virus itself. If you get a natural infection, you get those exact same proteins in your body. So any long-term effects you would have from the proteins in the virus are the same long-term effects that can happen from a natural infection as well. The natural infection also comes with the bonus of potentially hospitalization and death. So really, if you're going to be exposed to those things either way, it's the safer option to do it and the one that at least protects you from these horrible outcomes. So it's a difficult case to make for, what happens 20, 30, 40 years down the road. Well, the same thing happens with any new medications that are out there. If you go to your doctor and you have cancer, they're going to recommend a chemotherapy drug that's brand new. It's cutting edge, but that also means it hasn't been tried for decades, and we can't tell you what's going to happen 20 years down the road. So that's kind of the uncertainty we always face. But we design these studies to show that they are as safe and effective as possible. And looking at the history of vaccines, we have not seen any vaccine that causes any type of long-term problems that we have to be concerned about 20, 30 years down the road. It's the natural infection that winds up typically causing those long-term problems where people can have the disease show up again sometime in their life, like chicken pox, or have post-polio syndrome or things like that decades later, where you wind up having essentially like polio all over again. So those kind of things happen with the natural infections, but not with the vaccines typically. When it comes to the laws about it, constitutionally, this is the foundation of public health law. Jacobson versus Massachusetts was this exact question in 1905. There was a law in Massachusetts that said you had to get a smallpox vaccine or you could pay a fine. And Jacobson said, I don't want the vaccine, I don't want to pay a fine. And it went all the way to the Supreme Court, and they said, well, this is something that public health can do. They can mandate these sorts of things. However, at this point in time, there is no law on the books in Nevada that says anybody other than students have to be vaccinated. So it would have to go through our legislature or some process from the governor. There would be a big legal side of this to put it all in place. And this is the kind of public debate we would have about, is this something we're willing to do as a community with all the negative and positive aspects of it, and make a decision as a population, this is something we want to do.
Okay, I have our next question here. This person says they've been fully vaccinated, but have been told that they still may have to test for quarantine. Why is that? And Carrie, maybe I can answer a little bit about the testing, and maybe you can address the quarantining. But if a person has verified that they're vaccinated, they would not be required to undergo the weekly COVID testing.
Thanks, Bill. I think I read that as if they've been exposed, right? So if you're fully vaccinated and you've been exposed and you're not symptomatic, then you would not need to quarantine. Now, the CDC did come out with some guidance last week, updated, saying if you're fully vaccinated and you've been exposed, then they are recommending that you get tested 3 to 5 days after your exposure. So you would not need to quarantine unless, again, you become symptomatic or you do test positive, then we would ask you to isolate. And if you're unvaccinated, that hasn't changed. At this point, we would ask you to quarantine for 10 days with the option to reduce that down to 7 days if you test negative on day 5 or later. And so it gets a little bit convoluted. So we just ask you to come to our wellness team and let us help you work through your individual situations.
Great, thank you so much, Carrie. So this might be for a couple of our panelists today. Do we have any data on the breakthrough cases, vaccinated individuals who have developed or tested positive for the COVID-19 infection within Nevada? And so I think that might be for Brian and for Pat, and how we're evaluating and or measuring whether or not we have breakthrough cases. Let's start with Brian. How's that?
So yes, we do test for breakthrough cases. As part of the interview, we ask if people have been vaccinated and try to include that in there. The Southern Nevada Health District publishes weekly reports of the breakthrough hospitalizations and deaths. That's really kind of the thing that the vaccine is actually very effective in preventing, and that's still something we're looking at. If you go to covid.southernnevadahealthdistrict.org/cases/breakthrough, you can see the weekly reports of how many people have been hospitalized. The July 29th report says, so far, we've had 178 people total hospitalized who have been vaccinated, compared to the thousands, obviously, that have been hospitalized and unvaccinated. So that data is out there. It just depends on exactly what's being published. It's right now the health district is completely overwhelmed with doing case investigations. So they're doing these standardized reports, but it's probably not going to be anything customizable that you'll be able to play with and see all the data. We know that the vaccine doesn't protect everybody. We know that's the case. We expect, even before we had the Delta variant, we knew that the vaccine reduced disease by 95%. So there's still some risk left over. There were going to be breakthrough cases. We know the risk is higher with breakthrough cases now, but that doesn't really mean anything. The vaccine is still doing an excellent job protecting against hospitalization and death, and it still is reducing the risk of regular infections.
Great, thank you, Brian. Hey, Pat, tell us a little bit about how those Delta variants are tested and evaluated.
Sure, and this is what public health does. Part of this is to be able to, people who are tested by the clinical labs have a PCR test that comes up as either positive or negative, but that's all they can identify. It's positive or negative. So a portion of those samples get sent to one of the two public health labs we hear, one up north, which is a state public health lab, and then we have the Southern Nevada Public Health Lab here in Las Vegas. And both of those labs can do what's called sequencing. So they actually go in and look at the various sequences of the genes, and then they're able to differentiate the various, the different variants that are there. And so that data then is provided to the state, the local public health, and then that information also gets sent up to the CDC. So as Brian mentioned before, a lot of what we're talking about here are things that public health has been doing for a long time for following multiple other types of infectious diseases, and the system works quite well. But we need to have those original samples, so people need to be tested with a for the PCR, and then that sample gets sent up to the public health labs, and they do the sequencing and send that result off to the state as well as the CDC.
Thanks, Pat. I think our next question I can direct to Sherry. Sherry, I read every day that cases are increasing and hospitalizations are going up. This is a scary environment. How safe are patients in the hospital?
I can say, great question. I can say that in the hospital, all of the healthcare workers are utilizing the protective equipment as they can and being as safe as they possibly can. People can't avoid going to the hospital if they're sick, but just know that your healthcare workers that are in the hospital are utilizing all of the tools that they have in their toolbox in order to protect you and help you to get out of the hospital, hopefully, you know, safe and without COVID or any other disease that you may or may not have when you came into the hospital. So I would say they're as safe as they could be. They're as safe as they were prior to COVID. But, you know, again, there are times that you can end up with an infection that was not yours when you came in.
Great, thank you so much, Sherry. And it's good to know. I mean, I know that the hospitals have everything that they have at their disposal to keep us safe. So the next question, and this might be for Brian. I know several people that have been fully vaccinated that tested positive after thinking it was allergies. Why is data not available on the number of breakthrough cases in Southern Nevada? And I think both you and Pat touched on this a little bit earlier, but you know, I think that's a concern that people have.
The data is available. It's something that is being collected, but it takes time to get all that information, analyze it, and put it out in a format that actually makes some sense. So the health district has never just published raw data. It's something that takes a little bit of skill to actually interpret. And the problem is if you put out the raw data, it gets completely misinterpreted and people read one wrong number and all of a sudden the entire vaccination program is undermined. So that data is out there. It's something we're collecting, but breakthrough cases are absolutely not unexpected. It's what happens with a vaccine that is not perfect. It really reduces your risk, but it doesn't eliminate your risk. I keep telling people in meetings, they say, oh, is this safe? Can we do that? And I said, well, it's not about safe or unsafe. It's about something that's safer or something that's less safe. A vaccine makes us a lot safer, but it is not perfect. Well, we're not going to have that transmission. So those cases are expected to show up. And it also comes down to who's being tested for it. And we have a lot of differences between severity and how people get tested at different rates and things like that. And the numbers can be very difficult to interpret as a result.
Great. So Pat, did you want to add anything to that, or are we good to go to the next question? Do you want to add anything?
No, I think Brian covered it. Once again, we have to have the sample in order to do the testing. So it is important that people go in and not just have the antigen test done, but we have the PCR test performed.
Great. Thank you so much, Pat and Brian.
So to the panel, we've seen in Florida that case numbers can easily reach and possibly exceed the worst numbers we saw months back. Is Nevada prepared for an explosion in cases similar to Florida?
So
I'm not sure what, let me answer that.
How's that?
I'm not sure what numbers they're looking at, but I feel like we've had an explosion like Florida. We led the nation in COVID cases, and our hospitals were able to keep up this time. So we don't want those things to happen, but in all the waves that we've hit so far, our hospitals have gotten right to the edge of being overwhelmed. And at this point, they're very, very busy, but we're not at the point where the system collapsed. So I think we've been dealing with that exact problem. We were one of the people, or one of the states leading the country for a while.
Yeah, if I could add to that, the Nevada Hospital Association meets on a regular basis to discuss hospitalizations as a whole, as a state. And they are very tightly scrutinized, and they do a lot of work to make sure that that availability is there. When we get to peak times like that, they implement things like not doing elective surgeries to make sure that they have availability for things like COVID and regular traumatic cases. So they are watching the case numbers very closely, and they work collectively to help solve the problem of availability and make sure that people can be taken care of.
Great, so thank you so much. So the next question, Greg, is probably going to go to you for a start, and then others can weigh in. With Clark County taking over direction over capacity and social distancing, with the increased case level as high as it is, why is social distancing and not being reinstated?
So I can't speak for the county and the commissioners and their decisions. I would be speculating, but what I can tell you is I understand how they come to these decisions. And so I'm going to go back to something that Brian said earlier. We can make a recommendation based completely on public health guidance, but we don't do that in a vacuum. There's the world around us, reality that we have to deal with. Social distancing and capacity limits are probably the least popular tool that we have to try to minimize cases. There's a lot of pushback from business and industry when we start trying to regulate capacity limits or social distancing. So what the county has chosen to do is to put their time and effort into vaccinations. And because that's the way that we're going to get out of this pandemic, is to increase our vaccination numbers. So they've implemented the county has implemented a mask mandate for those indoors, but we are putting our time and effort towards vaccinations, and we're working with national partners, federal level government. FEMA folks have been out in Clark County to those specific communities that have low vaccination rates to pass out information about vaccinations, answer questions, and the county has chosen to go that route and see it as a more fruitful venture. And I welcome anyone else's comments in that area as well.
I think that would be, I think you've got that one. Thank you so much, Greg. So, so Bill, this question might be for you. So if somebody is working completely remotely, do you still have to take weekly COVID tests? And if so, who pays for that test?
Yeah, and so I'm assuming when you say if they're working remotely that they are unvaccinated, yes, they would still need to get the weekly testing, for the fact that even if an individual is working remotely, there is the possibility that their supervisor would call them into an in-person meeting or something like that. And so we would require that, and that standard would be applied equally to all employees. As far as the payment for that, I don't believe that the testing payment methodology would change any different than what we have right now. Which I think I can ask the next question, and I'm not sure if this is perhaps a Carrie question or maybe one that we have to get back on, but are there any metrics that we would hit a certain level where CSN would go or pivot virtually? And I don't know that any of those metrics have been established.
Yeah, so I think Carrie and I can answer that, and also with Greg, but I would just still kind of circle back to the points that Brian and Sherry and Pat and Greg and Carrie and I have all also communicated, is that the best thing that we can do is get vaccinated and to increase that vaccination level throughout our community and our CSN family with students and others and our college community. But there is no set target or metric that is has been established. We work obviously under the direction of not just the state, but the county as well as NSHE. So we do take that leadership and that guidance in collaboration with all of this environment. And so there's no set metric that has been established, but we do monitor the environment on an ongoing basis.
Okay.
So next question might be good for Sherry. Gonna give this one to Sherry and maybe to Brian as well. How can this panel help me with how to convince someone to get vaccinated if they are afraid to or don't think that it's necessary?
Great question. What I think is that you have to really approach a person that you're trying to get vaccinated with a lot of sincerity. You have to look at, if being sincere about that you really want to get them vaccinated because it's going to help them. I've done it with my family members and we've talked about it, and trying to convince people to be vaccinated. You really can't convince anybody to be vaccinated, but you can support them with their decision, as well as give them the science behind it. The science is the thing that we all need to look at. What is the science behind it? Am I going to get vaccinated? Am I going to get sick? What's going to happen? Can I transmit? All of the things that we've been talking about is those things that will help them make a decision if they want to be vaccinated.
Great, thank you so much, Sherry. So Bill, do you want to ask the next question?
Sure. Great, and I open this to the panel. Is there any updates or news about an opportunity for those already vaccinated, or is it necessary for those that have been vaccinated to perhaps get a booster shot later this year?
Brian, how about you?
Sure. So this is something we're talking about. The question is, what would that booster dose be? What's the timing on it? What's the recommendation? So it's something that's being discussed, but to jump to the next step of, hey, we need more shots for people when we're still struggling to get those first rounds of shots in people is a huge challenge. The vaccine itself, we could just give you another dose potentially to boost an immune response, or we could wind up changing the vaccine itself and slightly changing the sequence of the mRNA to protect better against other strains. These are all things that are being discussed and studied. I don't think we have a fixed answer to that yet, but it is something that everybody's looking at, and it is something that we've talked about. The most discussion I've seen has been about people who've got the J&J vaccine, the single dose series, potentially getting an mRNA vaccine as a second dose, which will provide them better protection then. But it's something that's kind of on the horizon, but we're still struggling through getting the first dose into people. And so in some ways it's a bit premature, but we obviously have to look down the road and see what's next for trying to protect our population.
Great, thank you so much, Brian. So I think you touched on this earlier and just want to make sure that we respond to this individual's question, but when will children be able to get the vaccination? And we're talking those that are under 12 years of age or younger. Any thoughts?
So the answer is once it's approved, and the approval process is ongoing. So it takes time to actually study vaccines in people. What you have to do is vaccinate a bunch of people, give other people the placebo, and then compare the differences. So it's not something we can do overnight. We have to let enough time pass to show that there truly is a difference between those groups. We did it with adults. And now we are moving toward younger and younger populations. It's not that it's unsafe in kids, we just haven't done the studies to show that it is safe, which it likely is, to show that it's safe and effective. But kids are not just little adults, so we have to study that. And we want to make sure we do a thorough job to make sure that it's both safe and effective. So it's in the works. It's something that the trials are going on right now, but the trials are not completed. So I would expect maybe the end of this year, we'll hear more information about it moving toward the point where people of all ages will be able to get vaccinated. I will add, if we add kids to this vaccine later this year, the progress we've made, the speed with which we've done this is absolutely astounding. To go from a virus that we didn't know 2 years ago to have our entire population be eligible to get vaccinated in basically 2 years is absolutely incredible. I know we get frustrated that it's not here this week. It took us decades to create vaccines for other things, and we've been able to basically control this disease within months of discovering it. And to me, that's absolutely amazing. I know it's not fast enough for people who are getting sick or worried about their kids. The progress on this, though, has been absolutely incredible, and the speed with which we've been able to produce these safe and effective vaccines is just, it gives me a lot of hope for the future for our control of all kinds of infectious diseases.
Thanks, Brian. So we know that vaccinated people get COVID as well. Why are these individuals not being asked to test?
I can take that one. So if you become symptomatic at any point, vaccinated or unvaccinated, we will ask you to get tested. That has been really something standing. We want everybody to get tested if you are symptomatic. The CDC did come out last week with some updated guidance that if you are fully vaccinated and have been exposed, then they are recommending getting tested again 3 to 5 days out. So we are seeing some of that data with the new Delta variant, and some things are changing where we're going to ask more people to get tested depending on the situation.
Thank you, Carrie. So we do have a lot of questions still in the queue, and just wanted to ask our panelists if you're good if we extend a little bit longer past 4 o'clock, and we'll connect with you offline about that, because we have a lot of questions still out there. But I wanted to ask the next question, and this might be for Pat. So I was notified that my child was a close contact to a positive COVID case. When I tried to get testing, I was told that only certain tests are available. How do I know which tests are available for children?
So this goes back to that FDA regulatory component. When the test kit manufacturers get approval from the FDA, they're going to identify a specific population that this test is going to be accurate in or can be performed in. So the laboratory then makes a decision about, or a testing lab makes a decision about which tests they're going to put in place in their facility. And so it, for example, this QuickVue at-home over-the-counter COVID test that I have here is acceptable in children over 2 years and in persons over 2 years old. However, if you were to do some new molecular testing that's available that hasn't been as proven as accurate as the PCR testing, it has not been proven for testing in children. So I guess the bottom line is that it all depends upon which test has the laboratory put in place at their facility, and the laboratory is required to follow the FDA approved manufacturer's instructions. And if those instructions state that the test cannot be performed in a specific age population, then the lab can't perform that. To answer your question about how you can find that information out, well, if you're doing at-home testing, read the package insert and identify what the manufacturer says is acceptable, and then you need to ask the facility if you can make if you're going to make an appointment to go into the facility to be tested. Then you need to ask them up front, let them know this is a child. Can you do the testing? Unfortunately, there's no list that I know of. Maybe Brian knows, but I don't know of a list where every laboratory in the state is providing which test they perform at their facility and which technique there is. So it is going to have to be each person finding out at the facility they're seeking care at whether they can perform testing on a child.
Hey, so thank you so much, Pat. So Bill, this might be for you. You know, obviously we're looking at some effort on mandatory vaccinations. If an employee does not get vaccinated, will that jeopardize their jobs? Not sure that we know that information right now.
Yeah, that's a good question. The only policy that's going to be in place right now is that if an employee is not vaccinated, they'll have to get their weekly testing. And that's the policy that's in place right now. And obviously, we want to have some conversations with the person, direct them to resources, much like what we're doing today, if there's some hesitancy to get them some information. But the only policy that I'm aware of is that the individual would have to get the testing as required. So I guess I can ask the next question, and this may go to Brian or to Sherry. Is it safe to go to restaurants and events?
Brian, you want to take that one? I'll chime in after.
So as I said earlier, I don't say things are safe or unsafe. It's a continuum of risk. If you're going to a crowded restaurant, not wearing a mask, and all the people in that restaurant are unvaccinated, it's going to be riskier than if you're at a sparsely populated restaurant and you're sitting outside. So it's one of those things that you have to look at your individual risk, your health, and your status. If you're vaccinated, you're otherwise healthy, the risk is going to be lower than if you're unvaccinated with a lot of underlying conditions. So there isn't a blanket statement. There is risk anytime you're around other people in public. And you have to decide that going to that restaurant, the reward is worth the risk that you take from being out in public around other people, and make that decision for yourself individually. And we all have different levels that we're willing to accept in our lives.
Perfect, Brian.
Great. All right, so this might be for Greg. For you, is there any talk about rolling out a vaccine passport app in Nevada?
So I've not heard any discussion about a vaccine passport in Nevada. I know that idea was brought up early on during this pandemic, and folks railed against that idea. Businesses were not in favor of taking that action. The deeper that we go into this pandemic, the more that we see folks willing to at least ask the question of participants or their guests of their vaccination status. So I don't know where we're going in that regard, but I've not heard any discussion. I don't know if any of our other panelists might have heard.
All right, I'll go to our next question, and this may be for Greg. Why, when Southern Nevada is considered one of the highest transmission rate areas, has Clark County not taken stronger mitigation actions, perhaps such as face coverings for employees?
So I think what we've seen now in Clark County, due to the governor's directive, in areas of high transmission, folks are required to wear their mask indoors, and that just makes sense. If you're going to be indoors confined with people you may or may not know their vaccination status, wearing a mask can help. It's not going to hurt you wearing the mask, but it potentially could help you. I think, and that's what we've seen from the governor's office now. Taking stronger action. The only other mitigation measures really are to talk about requiring social distancing again and requiring capacity limits again. And there's not a lot of support for that community-wide. And we have to make these decisions based on how it's going to affect the community and the risk that we're willing to assume. And so again, the Clark County has invested in vaccinations and trying to get that vaccination rate up and getting the message out that that's the way that we're going to survive this pandemic.
Thank you so much, Greg. So this next one, I'm not quite sure who might be the best person to answer this question. I have not heard anything about the flu shots for this coming year. Do we still need to get flu shots when they become available? Sherry, can we start with you?
Yes, and I do think that people should get their flu shots regardless, because COVID and flu, they kind of act the same. So you want to get your flu shot. You want to be protected against the flu. You want to make sure that your family is protected against the flu. So I would suggest flu shots. Yes, definitely.
Thanks, Sherry. So question to the group, why is the Delta variant so contagious? And what's the best way to protect ourselves and our family?
I'll take that one. It's so contagious because once it gets into your body, the viral loads are about 1,000 times what the previous virus was. So you're producing that much more virus. So every time you cough or sneeze or talk, there's that much more coming out of an infected person. And the simple answer, the best way to protect yourself, even with the Delta variant, is to get vaccinated. It doesn't matter about all the other things that we do. The vaccine is far better than anything else we can do to stop disease transmission. If you have only one action to take to stop disease transmission, vaccination would be it.
Okay, so the next one is a question I'm not quite sure who would be best to address this, but CSN has been developing a CSN COVID tracing app for more than a year. Why isn't it available yet? Why isn't the Bluetooth-based tracking app more of a priority? I'm not sure we may have to kind of get to the next question, because I don't think that we're developing our own app. We do have our remote health assessment, and Carrie, you might want to touch base on that. How's that?
We do, yes. In our CSN mobile safety app, we have a self-health questionnaire to go through that self-check before you come to campus. Are you having symptoms? Have you been recently exposed? And that function in the app doesn't record any answers. It's just a nice little checklist you can go through daily before you come to campus.
All right, and this may be a question for Brian and Sherry. Studies the effectiveness of masks range from little bit benefit to moderate benefit. What is the consensus of the effectiveness of masks to limit the spread of the coronavirus?
I would say the consensus is a non-zero reduction in the transmission of COVID. It depends on the type of mask, and that's why you're seeing different answers in the studies. It depends on exactly what type of mask you're using, what type of fabric, what type of weave, is it wet, is it clean, all those kind of things. But we know that there is a reduction in the amount of virus that you're putting out. And think of it like this, even if it only reduces it 10% at a population level, that is a lot of cases. And so even small things can make a big difference at the population level.
And I'll just add on to Brian, and the way the mask is worn. I see a lot of people with mask under your nose, under your chin. The way you wear your mask is gonna help you to be, prevent catching COVID or spreading COVID. So the way the mask is worn is really important as well.
So Sherry, this next question is for you. So you said that it's important to be vaccinated to protect those around us. If we're wearing masks and maintaining social distancing, then why are vaccines necessary to protect others? Can you please expand on that and elaborate a little bit more?
Well, vaccine is, as Brian has said before, is the number one way, the simplest way to protect from spreading the COVID vaccine. Spreading the COVID virus. So having a vaccine will help you to prevent from getting COVID as well as spreading COVID. So it's really important. That's like the number one way. We can wear masks, which will decrease. We can socially distance, which would also decrease. But the vaccine is the number one thing that's going to keep us safe from either spreading or contracting the COVID virus.
Thanks, Sherry. I think our next question is for Carrie. I'm a little nervous knowing COVID positive community members are coming in and out of the student union to get tested and have symptoms. Half the time they're lost and don't know where to go. As we know, the positivity rates are going up and many volunteers are coming into our office space to use them as break rooms. We share restrooms, etc. What is my risk even while using a mask?
That's a great question, and it's a very valid concern. And so one of the initiatives we're working on is to increase signage to make sure that we're routing people to the proper testing and vaccine locations. And we're also working to relocate those services out of our buildings on campus and move them to a remote parking lot location in a modular building. That way we're not having so much cross traffic, especially as the semester begins. We'll keep it in a remote area so we can still be able to provide those very important services, but also just have that lower risk within our own buildings.
Thank you so much. So the next question is going to be for you, Carrie, and for Greg. Are social distancing policies or campus closures being considered if infection rates become worse? If we enforce a vaccine policy for students and employees, how will we deal with the large amount of civilians that like to use our public services who do not fall under the category of students or employees when they're on campus? So Carrie, can we start with you and then turn it over to Greg?
Sure, like we mentioned before, we don't really have any trigger points at this point in time, and social distancing is not a mitigation measure currently being used by the county. But we are, for one, like I mentioned with the vaccines and testing, we're going to try to relocate that, and we try to handle public coming onto our campuses, just informing them with signage. Through our events, we inform people of our requirements to be here on campus.
Greg, did you want to add anything to that?
Yeah, I think, again, a valid concern. You have people coming onto the campus who are not necessarily students or employees. So again, I think that's exactly right what Carrie said. We're using signage where if they're coming for an event or they have an appointment, they're being made aware that of our policy to wear a mask indoors. But that is definitely a concern, and we'll probably be doing some more work in that regard to account for those people that come onto the campus.
Thanks, Greg. I think our next question's for Brian. Brian, COVID-19 Daily News Reports posted a peer-reviewed report concerning the vaccination, prior infection, and neither vaccination and prior infection. It revealed that antibodies from infection are present after 9 months and protects from different COVID strains. It also stated one vaccination, if previously infected, is as strong as someone who has been fully inoculated. Why are these reports being ignored and not shared with the public?
I don't think any reports are being ignored or not shared with the public. I think it's really a misunderstanding of the way science works and has always worked. People do research. They first, a lot of times we're seeing it now where they release it in a non-peer-reviewed format where anybody can read it. It goes through peer review and then it gets released out to the world. And the way we look at the relationship between an exposure and an outcome, cause and effect, is the sum of the evidence and not just a single study. So that any findings from any of those studies are going to be considered alongside of every other study in setting our policy. So I don't think any of those things are being ignored, and I don't think they're being withheld from the public at all. I think it's just a misunderstanding of the way science works. We don't get front page headlines most of the time when we put out a paper on some new finding. It'd be great if we did, but we put out new things all the time, and science kind of moves slowly, takes all those things and looks at the combination of all that when we're setting our policies. So I don't think it's being ignored at all, and I don't think it's being hidden at all.
Thank you, Brian. So Pat, this is for you. So if I have had COVID, what good is testing? And if I will test positive, but I will not be contagious and have no outward signs, so what happens there? I will show a positive result and have no signs or symptoms. Do I need to stay at home? Will I be able to work remotely? So don't worry about the working remotely. We'll let our case management team handle that. But I've had COVID. I'm going to test positive. And so what's the value of getting tested and if I'm not symptomatic? So that might be for you and for Carrie. So Pat, let's start with you.
So the way I understand this is that they had signs or symptoms and they were tested and they tested positive?
No, they had COVID and then they're continuing to get tested positive because they've already had COVID.
Oh, okay. So that goes back to what I had said before, that the RNA, you're going to be able to still pick up the RNA in the PCR test, could be for weeks, could even be for months. The question on testing, and Brian could probably, I think CDC's recommendation on that is you don't have to test again in order to get out of quarantine. I thought that this was based more on status rather than having a test to have proof of the fact that you're no longer contagious. Is that correct?
I think the problem is people can continue to shed the virus at levels where they're not infectious anymore for a while after they've recovered. So after 10 days of onset, you were considered no longer infectious and you can leave isolation at that point. If we keep retesting you, you might still keep testing positive, but that doesn't mean you're infectious. Those are two very, very different things. And there isn't a test that can differentiate between presence of the virus and infectiousness, really.
Yeah, and if you have any follow-up questions to that, and I know that Carrie is going to jump in, but you can always email us at wellness@csn.edu. But Carrie, go ahead.
Yeah, I'll just add to that. So we do, if you test positive and you've been isolating at home, we check in with you towards the end of quarantine, and we want to make sure you've met the symptom-based requirements to return, which is, like Brian mentioned, 10 days from your onset of symptoms. You don't have a fever, you're generally feeling better, and we don't require a negative test to return to work. As long as you meet that criteria, you would be able to come back.
Thanks, Carrie. And Pat, this may be to you. What's the difference between a test result stating not detected versus negative?
So some of that depends upon how the lab is going to interpret the result. Typically, what you're going to get with a PCR test is you're going to get a not detected or detected result, versus with an antigen test, you're going to get a negative or a positive result. So it may depend upon which type of test it is that you had performed. They both mean the same thing. Essentially, it's not detected, negative, but it is going to depend upon which type of test it is that you had performed.
Okay, so Pat, I'm sorry, this is another question for you. So do COVID tests still require a long swab jammed up your nose? So can you help us to respond to that one?
Sure. So it depends on the test. There are some new tests out there that are saliva based, where you actually spit into a tube or they collect a sample with a swab. We can do nasal swabs now, where we're just collecting from the front of the nose. Ideally, you'd want to, if you're many of the PCR tests are going to require the swab that goes all the way back, which is a nasal pharyngeal swab. This still also goes back to, what does the FDA approved manufacturer's instructions state? So if the instructions for the test that's being performed says that you can only perform this test with a nasal pharyngeal swab, then yes, you're going to have that long swab that goes up in your nose. If the manufacturer's instructions state that you can either use an NP or you can use a nasal swab, then you could have either one of those. So it all depends upon what does the FDA approved manufacturer state as the type of sample that it's going to be collected.
So our next question probably could go to Carrie. Carrie, is the plexiglass that's been installed in some of the offices and workstations considered a substitute for face coverings?
So the plexiglass we installed throughout the campuses in our high traffic customer service areas are meant to be an extra barrier and protection, because we get a lot of interactions with students and customers in those areas. So if you're working behind plexiglass, it's not a substitute for your face covering. You would still need to wear that.
Great, thank you. So Brian, this next question is for you. So a CDC study shows that 74% of people that were infected in a COVID outbreak were fully vaccinated. Why would you only test the unvaccinated individuals?
They don't test the unvaccinated individuals. If it was an outbreak, they would have tested everybody to see what percent of people were infected. Looking at an outbreak really doesn't give us a good picture of what happens in general in the public. It's a special situation. You may have had a person with a ridiculously high viral load. Everybody's together singing, doing things that put a lot of virus into the air. And so, and the people that were there had weak immune systems. So there's a lot of combinations that go into that make it interesting to look at in isolation as an outbreak, but it really doesn't tell us much. And we just want to test everybody there to see what's going on. So that was part of a particular cluster investigation. Really doesn't mean anything in the bigger picture.
So the FDA is on track to officially approve the vaccine. What are some of the extra steps, data that the FDA need for official approval versus the emergency approval? It's a longer data longevity, like needing a certain amount of months of data. So I guess the question is, what is the difference, or what steps need to be taken to go from full approval to the emergency approval?
So let me jump on this one. So the emergency approval required a shorter follow-up time than the full approval. The follow-up data for the emergency was a couple months. The full approval, I think, was 6 months. They were asking basically for 6 months more data to do the full approval. So it's really just the amount of time they followed people over. They also request additional information from all the people that got it, what happened with the side effects, any of the additional studies that came out looking at how well it worked actually in the population versus just in their clinical trials. So with the full approval, they want to look at everything that we've kind of done around it and look longer term than we did in just the emergency use. The difference is we have the emergency use because of the pressing need in some sort of public health emergency. This is the exact situation emergency use was designed for. You wouldn't see the same thing for a cholesterol medication or a medication for migraines or something like that. They would make you go through that full longer process because there isn't the same pressing need as we see with a pandemic like we have right now.
So thank you, Brian. So I also want to thank all the participants today and the panelists. We are going to extend for another 15 minutes to 4:15, and any of the unanswered questions, we will circle back to all of the panelists and post them on our COVID Return to Campus page. So the next question is probably for Greg and for Brian. So with the number of COVID cases approaching the same level of cases as this time last year, is there any medical reason we should be following different mandates, particularly as people are returning to campus and not having social distancing? I am paraphrasing that question, but if we could get an answer, I think from Brian and from Greg. Thanks. Brian, start with you.
So the big difference between this year and last year is the availability of the vaccine. Everything that we've done for social distancing, masking, all those things were a bridge to get us to the point where everyone was fully vaccinated. That has been the goal the entire time, and those other things were all steps along the way. And so that's why we are focusing so much on the vaccine right now, because unlike a year ago, we have a vaccine. You can go out today and get vaccinated, and that is what's going to get us out of this pandemic. And so that's the difference between last year and this year, and why we're approaching some of those things differently. Plus, the vaccine is just that much more effective than any other tool that we have, and that's why we're putting all our eggs, unfortunately, in that basket. But we've had to go back to a few of these other things because it's been difficult to get everyone to get vaccinated to the levels we need.
Yeah, I
Our
think,
next question. I'm sorry, Greg, go ahead.
no, I was just going to say, I think that's absolutely accurate. You know, the measures that we had in place were stopgaps along the way. So if we find ourselves in a position where we cannot raise our vaccination levels, there's a chance we could see some of those actions come back, but we'll have to see what happens.
Okay. Thanks, Greg. And maybe next question, we can start with you, Sherry, that an individual read an article saying that COVID can impact long-term cognitive ability. Can you guys talk a little bit about that?
I have not read that article. However, anytime that you have decreased oxygenation to the brain, because COVID does actually affect the lungs, when you have decreased oxygenation to the brain, it can affect your cognitive ability, your ability to stay awake, your ability to think. Decreased blood, oxygenated blood getting to the brain will actually do that to you. Now, if it's is it a long-term effect? Maybe Brian can answer that question, but I haven't read that it's a long-term effect.
The COVID brain fog, as a lot of people describe it, is something that's been described in some people who are the COVID long haulers, the people that have kind of struggled to recover from this. And they report decreased cognitive ability and some things like that may be temporary, could be potentially permanent. I don't think we know yet until we see what happens as these long haulers start to recover from it. And so this is something that's been reported. The main symptoms we see long term tend to be respiratory ones, because that's where the problems really were, where a few months later people are still getting winded walking up a short flight of steps or things like that. But it is one of those things that we've seen in some of the COVID long haulers, and we're trying to understand that better. I don't think we quite know what the prognosis is at a certain point, because we're talking about a disease we've only been dealing with for a year and a half, so we don't have a lot of data. Plus, even the people that have the long haul symptoms, there aren't a lot of them. It's still a fairly rare sort of thing to have, where the serious long haul symptoms are around for a while. We're just getting enough of them to study to figure out what these long haul symptoms are and how they affect people and when they'll get better.
All right, thank you, Brian. And so Sherry, this question is also for you. Would you address the myth of COVID vaccine and how it may affect women's reproductive health?
Actually, I haven't seen any studies that that getting the COVID vaccine affects the actual reproductive systems of a female. The thing that I would say again is the first thing that the person needs to do is to contact their provider. They need to get with their provider and find out if there's any underlying conditions that may be affected from the COVID vaccine, but I've not heard that it will affect anything or having to do with anything with your reproductive.
And can I add something on this one? So there was a paper, or probably more of a social media thing, that came out some months ago, where people trying to say there was some overlap between a few of the base pair sequence in the COVID vaccine and a protein that's found in the uterus. Therefore, if you get the vaccine, your body's going to attack the uterus and destroy it. A complete misunderstanding of even basic biology. It's like saying the word "the" was in the Constitution and in my chemistry textbook, so they have some sort of connection. No, not at all. That was one of the things that started with this. It's understandable that younger people are concerned about the potential fertility effects from this, but we've seen, like Sherry said, there have been no studies that have shown any sort of connection between COVID and any sorts of problems with fertility. We have not seen anything between the natural disease and fertility as well. If we had a problem with the vaccine, we'd likely see the same issue from natural infection. We have not seen any sort of decreased fertility rates. We have not seen any increases in miscarriage or anything like that. If a pregnant woman near the end of her pregnancy gets infected, it can be a serious problem, but that's just a problem being pregnant and getting a disease on top of it. It has not affected our birth rates at all or anything like that. We have no connection between the vaccine and any sort of issues related to fertility. So I know that has scared a lot of people, and they think, what happens if years down the road I get this vaccine and can't get pregnant? There is no evidence there is any remote connection between the vaccine and any sort of fertility issues.
Thanks, Brian. Do we know how fast Nevada can detect and then notify the public of both new variants and the arrival of current variants into the state?
Pat, you want to take that, or you want me to?
Well, some of that quickness is going to be based upon whether the state public health labs have samples. So this goes back to ensuring that the samples are collected, tested, and screened at the clinical sites, and then those samples are sent up to the state. And I believe that both state laboratories are performing sequencing as quickly as possible. And I think that when the Delta variant became available, Dr. Pandori up north was fairly quick. Brian, at least a week, maybe 10 days to get the results out. So I think they've tried to be very transparent and they're working as quickly as possible to get those results out. But it all depends upon having samples to test to be able to identify them.
And I think the other issue with it is defining what a variant is. Mutations happen all the time. We find changes in viruses within a person. And so the fact that they identify one small change doesn't mean they're going to sound the alarm. It has to be a change that's meaningful and something that's now spreading in our population. So they're able to detect those small changes, but they are not testing every single person who has COVID. So if you're the person that creates that variant in your body because you weren't vaccinated, you got infected, and you're now producing this one, if you don't get tested, they're never going to know it. It's going to be a while before it spreads till they can actually say we have this new variant in Southern Nevada.
Okay, so the next question might be for you, Brian. Not quite sure if I have this correctly, but why might there be speculation that the vaccine will make people magnetized? I'm wondering if this was misinterpreted from the science, and I can better explain this to people if this is incorrect. Can you share some insight about that, you or Pat?
Yeah, it actually came from a TikTok or Instagram post or something like that, where the person got vaccinated and they stuck a magnet to their skin and it didn't fall off, and they said, "Oh, I'm magnetized now." It was just complete garbage. So it came from a social media post. I mean, the guy just kind of had a tape on the back of a magnet to show that it actually made him do that. There's no basis in science. There's no basis in reality. If you stick something to your body and you have a little moisture on your skin, things are going to stick to you. It doesn't mean you're magnetized or anything like that. That's where it all came from. So there's absolutely no truth to it. It's completely out of some stupid post on social media. And it's such a widespread misperception now that it's the first thing the CDC lists on one of their pages about all the misinformation that's going around about COVID. The vaccine does not make you magnetic. And it's funny that people would even think that. It's not like the vaccine's full of iron and your blood is. So, a magnet should stick to your blood. It doesn't. It's not going to make you magnetized.
Hey, Bill, I think we're good to go, and we can move on to the next question on that response. Thank you.
A good question for the panel to jump in on. Why make vaccinations mandatory if it's not 100% effective? And I think we've addressed this a little bit, but maybe we can expand and unpack on that question just a bit.
Well, I'll jump in on this one. Why make seatbelts mandatory if they don't prevent 100% of fatal car accidents? Why make bicycle helmets mandatory if they don't prevent 100% of people from dying? It's not about completely stopping something. It's about significantly reducing the risk. And not only does it reduce the risk of you, it helps protect things at the population level, because essentially it helps put out the fire by removing all the fuel.
Well said.
Okay, so the next one seems like the mask is more effective than the vaccine. Is that correct? Sherry, let's start with you, and then we'll shift to Brian.
As we said before, the mask is just a stopgap. It is just a stopgap that will, keep us from spreading or protect us from receiving particles that are in the air. So it's just one of those things until we get to everybody being vaccinated.
All right, Brian, jump in on the vaccination and why face coverings are really important until we get there.
Well, the face coverings will reduce some % of the risk of transmission, not as much as the vaccine does. You put the two of them together, you're going to have even more protection than either one alone. But if I could just get one thing, it would be the vaccine, and I would never wear a mask if I just had to pick one thing, because it's that much of a difference in the protection it gives.
Thanks, Brian. I think perhaps this next question is for you. Every virus mutates. So how is a vaccine going to help resolve this? I don't think getting a vaccine is going to help the virus from mutating and becoming resistant to the vaccine.
Well, it actually will, because if we vaccinate enough people, we slow down the number of cases in the community. The fewer cases, the fewer chances we are to have a mutation. If you infect 1 million people, there are going to be more mutations than if you only infect 100 people. And so by stopping transmission of disease, we stop the occurrence of more new mutations. It doesn't completely eliminate it, but it does slow things down a lot. Plus, the vaccine is effective even when mutations do occur, because it is not so specific to a particular sequence on that virus that it can't recognize other ones. It's kind of like if you hear the original of the song, you hear a cover of the song, you're going to recognize both of those things. Even though it's different, the immune system is the same thing. It can recognize the acoustic version and the live version, all those things without a problem. Every once in a while, it gets really, really strange and you have something that it's hard for it to recognize. But for the most part, even with the changes, it does recognize it.
All right, so this might be for you, Brian, and for Pat. So if a variant becomes resistant to the vaccine, how fast can we adapt the mRNA vaccines? If we adjusted the mRNA to target a different type of spike protein, for example, would it still have to go through as many clinical trials? That's a pretty technical question, and I know that we've got an amazing group of people to answer that.
So any of these vaccines are still going to have to go through some type of clinical trial. The FDA is going to make some decisions at that point as to how extensive they would need that to be. And then the manufacturers will follow that. The advantage of the mRNA is, as Brian said, is there are ways to tweak this quicker than what we have with some of the other types of vaccines that we've had. And so there could be a faster ability to be able to get a vaccine created and to be able to do the clinical trials.
When we produced the original vaccine, we spent decades working on a process that allowed us to create this vaccine over a weekend. Literally over a couple of days, they created the candidate vaccine that we are using now, which is absolutely amazing. And so because of that, we can very easily change the sequence. The manufacturing changes are not a big deal. It's not really hard to do biologically, but we do have to show that it is safe and effective. So if we pick a completely different surface protein, that's going to take a lot more work than if we slightly tweak the surface protein that we're using right now. It's kind of like we don't have to go through the full clinical trials every year for the influenza vaccine because we know we're picking different strains and it's the same process and things like that. So it depends on how many changes there are. The more changes, the more studies we'll have to do to show that it's equivalent or better than the vaccines that are out there.
Thanks, Brian. I think our next question's for Carrie. And so from what I understand, the virus is incredibly small and some masks will prevent the spread better than others. Why is the policy worded as a face covering rather than informing us as to what types of masks are more effective?
I think the term face covering really came out last year when it was all new and face masks weren't readily available for purchasing. So, you know, back in the time when they even had directions on how to sew a face covering on the CDC website. So I think that's where that term originated. But you're correct, there are some masks that are protective, certain types of surgical masks or even respirators. But again, those aren't always widely available. So the mandate really from the state is to wear some type of face covering that covers your mouth and nose, and that's what the general guidance is. But as you'll see in our hospitals, our healthcare providers, they will wear a more protective mask because of their level of exposure in hospitals and clinics.
Great. So Brian, I think this one might be for you. So with reports of the Lambda variant, 1,000 US cases, being vaccine resistant, what are the steps being taken now?
So the Lambda variant's one that first showed up in Peru. There have been some cases that have shown up in the US. It's not that it's vaccine resistant, because just like the safety issue, resistance is a continuum. It's just the vaccine will be less effective against certain variants. So it's something we're monitoring. If it doesn't spread more easily, then it really won't take over. The Delta variant will still remain the dominant strain, and so the Lambda variant won't be one that we deal with all that often. Right now, basically, the Delta variant spreads so well that it's crowded out all the rest of the viruses that are out there. So that includes the Lambda one. It can't really get that much of a foothold, but we're still continuing to test people, do the surveillance, look for it, and if that becomes the dominant strain, and it does truly show that it's less resistant to the vaccine in a meaningful amount, then we'll have to consider how to deal with that particular issue.
All right, and I think we have time for one last question, and then I think we can maybe turn over to the panel for last thoughts. But I think this is a question maybe for the entire panel to weigh in on. Why is it so important we keep uninformed, unvaccinated people safe versus protecting those who have taken the initiative to keep themselves, their family members, and friends safe?
So let's start with Sherry, if that's okay. So Sherry, let's talk about why it's important to keep uninformed, unvaccinated people safe and versus taking the initiative to keep themselves and their families and friends.
Well, what I would say it is that we are community. We are a family. We are people. We want to make sure that other people stay as safe as we can make them. So taking the responsibility upon yourself to put face mask on or get vaccinated, just to help those people that may or may not understand what face coverings, vaccines, or any other thing mean, you know, keeping them, trying to keep our community safe. That's what I would say.
Great. Thank you, Sherry. Pat?
Yeah, I would agree with Sherry. It really does have to be a community. We need to ensure that we're coming together. And it isn't just uninformed people. There are other people who really can't get the vaccine for whatever reason. I mean, we're looking at children. So we've got a whole population here that we need to protect as well. And the best way we can do that is cocooning them by being able to ensure that we're all vaccinated so that they don't end up getting sick as well.
Great, thank you, Pat. So Brian.
I completely agree with what Sherry and Pat said, that it's really about community. But even if you want to take it from the most selfish standpoint, your house is going to be a lot less likely to burn down if your neighbors' houses aren't on fire. And so even if you're just thinking about yourself, you're protecting yourself by protecting everybody in the community, because disease like this doesn't just affect you, it spreads in a population, and you are part of that population.
Great, thank you, Brian. Carrie?
I would just add to really share your experience if you're a vaccinated person, and really we're all continuing to do our work to promote this vaccine, and really it's safe and effective, and it really is a community effort, but we can still reach out to those that are still on the fence. I think there's still work to be done.
Great, and Greg?
Yeah, I would say that this effort is we over me, right? We're looking at everyone's best interest and not just our own. I'm not saying to disregard your own safety. Take care of yourself, but think about how that impacts other people. And so, again, you know, this virus spreads through a community. So anything we can do to help prevent that is a good effort.
Right. So, Bill, I think we need to bring it home. I know that we extended this town hall from an hour and a half to an extra 15 minutes. And I just have to say a huge appreciation for this amazing panel, and just want to thank you. We have 100+ questions that are still remaining in the queue. And so I hate to ask you, but we're going to ask you back. We're going to ask you back. And this is really what's really important to our CSN community, to our family. And we really want to thank you so much for your time. And so if we could go on all the way till all the questions were resolved, I think we'd be here for about 3 more hours, but I want to be respectful of your time. But Bill, you want to bring us home and close us out?
Sure. Thanks, Patty. And again, I want to thank Pat and Brian and Sherry and Greg and Carrie for your expertise and answering these questions thoughtfully. And again, there are a lot of questions, but I think what we say is take this information, to what Carrie said, you know, spread this information to your colleagues and friends, because it is important, and we are in this together. And so again, as we close out, thank you to everyone. Thank you for attending this afternoon. Stay safe, and please also, any questions, reach out to wellness@csn.edu or to us in Human Resources, and we'll be glad to help you through whatever we can. Have a great afternoon.
Be safe, take care, and look for the next town hall. All right, thank you so much.